Finals SAQ71 Status Epilepticus. You are asked to review a 27-year-old male who is a known epileptic in convulsive status epilepticus. A. Define convulsive status epilepticus. According to the International League Against Epilepsy, all seizures lasting longer than 5 minutes constitute status epilepticus. SE can be classified based on the presence or absence of prominent motor symptoms and the degree of impaired consciousness. In convulsive status epilepticus, there is repeated generalized tonic-clonic seizures and post-ictal neurologic function between seizures. B. Outline your initial management of this patient, including the use of emergency antiepileptic drug therapy. Status epilepticus is a medical emergency. Adopt ABC approach. Assess and manage patients simultaneously. Antiepileptic drugs must be given without delay. Airway and breathing. Provide 15 liters per minute oxygen via non-rebreathing mask. Assess airway patency and proceed with RSI if patient is unable to protect their own airway. Continuous oxygen saturation monitoring. Maintain oxygenation. Circulation. Large bore IV access. Continuous ECG monitoring. NIBP monitoring until outline is cited. Stabilize the circulation. D. The seizure should be timed from its onset and vital signs recorded regularly. If the patient with convulsive status epilepticus has an individualized emergency management plan that is immediately available, administer medication as detailed in the plan. If the patient with convulsive status epilepticus does not have an individualized emergency management plan, buccal midazolam or rectal diazepam immediately as first-line treatment in the community, and IV lorazepam if IV access and resuscitation facilities are immediately available. First-line antiepileptics includes lorazepam, diazepam, and midazolam. For lorazepam, 0.1 mg per kg IV, given at a rate no faster than 2 mg per minute. Give a second dose if the seizure does not stop within 5 to 10 minutes after the first dose. Maximum adult dose 10 mg. If lorazepam is not available, diazepam 0.15 to 0.2 mg per kg IV may be given, maximum 10 mg per dose. This may be repeated once more. For midazolam, if IV access has not been established, intramuscular midazolam may be administered at a dose of 10 mg for all patients weighing more than 40 kg. If convulsive SE does not respond to 2 doses of benzodiazepine, second-line treatment includes levetiracetam, phenytoin, and sodium valproate. Levetiracetam may be quicker to administer and have fewer adverse effects compared to the alternative options. So far, there is no clear evidence that any one of these options are superior. If convulsive SE does not respond to a second-line treatment, consider trying an alternative second-line treatment option under expert guidance. If convulsive status epilepticus does not respond to second-line treatment, consider third-line options such as phenobarbital and general anesthesia. Anesthetic doses of thiopental, midazolam, pentobarbital, or propofol may be administered. This should be done with continuous EEG monitoring. Insert endotracheal tube and initiate IPPV prior to beginning continuous therapy. General anesthesia drugs may cause hypotension. Thus, vasopressors may be required to support adequate blood pressure. This table shows the drugs that are typically used in the treatment of status epilepticus, their loading dose, rate of administration, maintenance dose, and important side effects. Treat possible underlying causes of SE, such as hypoglycemia and alcohol withdrawal, which may need to be treated with additional medications, such as Pabrinex, glucose, and in women suspected of eclampsia, magnesium sulfate. Investigations to be ordered includes arterial blood gas, blood glucose, urea and electrolytes, calcium and magnesium levels, full blood count, coagulation profile, antiepileptic drug levels, toxicology screen, and EEG monitoring. Treat acidosis if severe. C. 60 minutes after your initial management, the patient continues in status epilepticus. What would be your further management? This is now refractory status. Rapid sequence induction using propofol or thiopental bolus followed by infusion. Provide ICU care with EEG monitoring. Chest X-ray to check endotracheal tube position and to check for aspiration. Identify and treat medical complications of SE. Consider possible non-epileptic underlying cause or trigger. Consider the need for brain imaging or lumbar puncture. D. What are the complications associated with refractory convulsive status epilepticus? Airway. Oral soft tissue injury or dental damage and airway obstruction. Respiratory. Aspiration, pneumonia, respiratory failure, hypoxemia, and pulmonary edema. Cardiac complications, myocardial infarction, hyper or hypotension, arrhythmias, cardiac arrest, and cardiogenic shock. Neurological complications, cerebral hypoxia, cerebral edema, cerebral hemorrhage, excitotoxic CNS injury, and coma. Hematology, DIVC, musculoskeletal, fractures and rhabdomyolysis, renal, acute kidney injury, hepatic, acute liver injury, metabolic complications, hyponatremia, hypoglycemia, hyperkalemia, metabolic acidosis, hyperthermia, systemic inflammatory response syndrome, and multi-organ failure. The treatment of status epilepticus is a medical emergency to avoid the development of the above-mentioned complications. The highest mortality occurs in elderly and in those with SE after a stroke or anoxia, whereas prognosis is more favorable among patients with prior history of epilepsy. Chairman's report, 47.1% pass rate. Additional Q&A. What are the main causes of SE? This includes infectious or structural brain lesions, toxic or metabolic derangements, low serum concentration of antiepileptic drugs, and in younger patients, febrile illness. Describe the classification and clinical presentation of SE. SE can be classified based on the presence or absence of prominent motor symptoms and the degree of impaired consciousness. The definition for convulsive status epilepticus has been mentioned earlier. For non-convulsive status epilepticus, continuous or fluctuating electrographic seizures occurs without any motor manifestations lasting more than 5 minutes. Clinically, non-specific signs may be seen, such as altered mental status, repetitive speech, impaired short-term memory, subtle eye movements, blinking, and facial myoclonic. Due to subtle clinical features, EEG monitoring is essential for its diagnosis. The third type is focal motor or sensory status epilepticus, i.e. epilepsia partialis continua. There is repetitive partial motor or sensory signs or symptoms of seizure not associated with altered consciousness or awareness. Describe the management of seizures in patients with pre-eclampsia. Magnesium sulfate remains the standard therapy. A loading dose of 4 grams IV should be given, followed by an infusion of 1 gram per hour for the next 24 hours to achieve a target therapeutic level of 3.5 to 7 MEq per liter magnesium. Recurrent seizures should be treated with additional magnesium bolus of 2 to 4 grams over 5 minutes. Patients treated with magnesium should be monitored for magnesium toxicity, including loss of patellar reflex and respiratory depression. Any evidence of toxicity should prompt discontinuation of magnesium infusion. The most effective treatment of seizures related to eclampsia remains delivery of the fetus and placenta. Describe the pathogenesis and treatment of postanoxic myoclonic SE. Postanoxic myoclonic SE is the occurrence of synchronous brief jerking in limbs, face, or diaphragm that is correlated with epileptiform activity on EEG. Jerks can be provoked by stimuli such as movement, touch, or sound. It is typically encountered in comatose patients who have survived asphyxia or suffered a cardiac arrest. It typically indicates severe neurologic damage and carries a very poor prognosis. Myoclonic SE is typically resistant to anti-seizure medications, including phenobarbital, phenytoin, and benzodiazepines. Some anecdotal evidence suggests that valproate may be effective in treating this syndrome. What general measures should be considered after the seizure has been controlled? It is important to establish the cause of seizure once it is controlled and the patient's condition is stabilized. Appropriate blood work and cultures should be completed. Lumbar puncture should be considered, if not already done, to rule out CNS infections and subarachnoid hemorrhage, and imaging with CT or MRI should be obtained to rule out structural CNS causes. Empirical antibiotics should be started if infection is suspected, and maintenance doses of anticonvulsants should be administered and adjusted on the basis of serum levels. These are my references. Thank you.